I think we have a critical mass. So welcome everyone to the third Implementation Science Beachside Chat, third of 5. I'm Allison Hamilton, your host, along with Cheng Lin. And thank you so much, Cheng, for being here. You want to say hi?
Thank you. Thank you for having me here.
Cheng is faculty on the UCLA Rapid, Rigorous, Relevant, or 3R Implementation Science Hub, which is funded through CHIPS and by NIMH. So we're so happy to be doing another one of these chats today. They've been super fun so far, and I have no doubt that today will be very fun as well with one of my dearest friends and colleagues. So I think we can go to the next slide, if you don't mind, Cheng. So it's my great privilege and honor and joy to introduce Geoff Curran, who has just been an absolutely amazing colleague and friend for many years. I'll try not to get emotional as we start the beachside chat, but we've been collaborating and working on implementation related topics and issues and thoughts and ideas for probably close to 2 decades. So it's just phenomenal to have him here with us today. He's one of our consultants on the 3R Hub. And as I'm guessing you all know, he pioneered the idea of hybrid designs and implementation research. And I remember when this was an idea on a poster, and it became, hugely influential on the field. And so it's fantastic for us to have this opportunity today to talk with Geoff about reflections and updates on hybrid designs. Geoff is a professor in the departments of pharmacy practice and psychiatry, and also director of the Center for Implementation Research at the University of Arkansas for Medical Sciences, and he's also a research health scientist with the Central Arkansas Veterans Healthcare System, and is known throughout the world for being one of the most amazing implementation scientists ever. So maybe you have a sense of how fond I am of this person here. So we're very excited to have a chat. And yes, we're recording and we can share the recording. So for anyone who hasn't attended a chat so far, welcome, and welcome back to everyone who has attended our prior chats. This is really truly meant to be a chat, not a formal presentation. We're gonna go out of slide mode momentarily after we just take a couple quick polls, but really what we want to do with these chats is have a chance to talk with experts such as Geoff about, kind of new and interesting things going on in the field, take a little bit of the pressure off of formal presentations, and also give the audience a chance to ask questions through the chat mechanism. We mostly rely on chat for your questions, but if you put a chat in or a question in the Q&A, Cheng or Elena will see that as well. So I'm just better with chat, so we tend to use chat, but it really is an opportunity for us to dialogue. It's not just about myself and Cheng chatting with Geoff, although we'd be very happy to do that. It's also about all of you having a chance to weigh in with your questions and comments and ideas. I also want to thank Elena, who's in the chat and who makes all of this happen. So thank you so much to Elena for setting this up today and keeping these chats going. So I think we can turn to our couple of poll questions and then we'll get started. So first, we just would like a feel for who is in our audience. So Cheng, do you want to run those?
So we have 2 poll questions. The first question is, do you primarily work in academia or government or nonprofit or industry or other? Okay, so we have the poll results. We out of 59 participants so far, majority, almost 80% works in academia, and 8% in government, 6% non-profit, 6% industry, and no others. So moving on to poll number 2. How familiar are you with hybrid designs? Would you say you have conducted or work on hybrid design studies, or you're familiar with hybrid design but have never conducted a hybrid design study, or you have heard about hybrid design but don't know what much about them, or you say you don't know what they are? Okay, so we have
Nice.
1/3 each.
It's
One
amazing.
third very very have conducted hybrid design, 1/3 familiar, 1/3 have heard but don't know much, and 8% don't know what they are. Okay, so I will stop share here and start the chat.
Great, thank you so much. That's interesting. Great mix of levels of familiarity with this, and I'm guessing there will be a lot of questions. So I think, Geoff, before we move to some of our the questions that we talked about discussing today, can you give us sort of a few minute version of just locating us with hybrid designs, and maybe a little bit about the history of developing these, and any kind of top things that you think folks should know as we enter into the chat?
Yeah, sure. So, first of all, I always like to say that, we were not the first ones to really do this kind of blend. There already were people out there who were, trying to do these combination type studies where people were trying to study at the same time in the same study the clinical effectiveness of some intervention, while also trying to answer some questions around implementation of that intervention in sort of varying degrees of emphasis. And so when we started to work on the first paper, we were just trying to, highlight that this was happening, emphasize that this might be a good idea to try to speed translation, which is kind of the point of our field. And we also wanted to bring some new thinking, systematic thinking to these possible combinations of trying to study these kind of two sides here at the same time in the same study. So that's when a group of us, largely from the VA, myself, Brian Mittman, who was the mentor on my NIDA K Award at the time, which was happening when we were talking about this stuff. Cheryl Stetler, Mark Bauer, and Geoff Pine. And so we started to try to figure this stuff out and say, all right, well, what are the kinds of combinations that we think are out there or that we want to try to propose and put together. We worked on this for, gosh, 1.5 to 2 years before we actually, published the paper. We settled on 3 hybrid types. One that was mostly focused on clinical effectiveness of the thing, of some intervention, but with a secondary focus on implementability of it. And, maybe studying context and, what might be needed in the future for implementation strategies. And then a hybrid type 3, as we called it, which was kind of the opposite, which was, focusing on comparing implementation strategies, but not at the expense of not looking at the effectiveness of the thing, the intervention. So adding some secondary analyses on the intervention and how it might be functioning as a result of the quality or amount of implementation. And then a hybrid type 2, which was kind of a dual focus on these issues, maybe as like a dual level randomized trial, comparing 2 interventions and 2 strategy components, or possibly still kind of focused on clinical effectiveness, but explicitly testing and implementation strategy or package kind of in a pilot test version to kind of move it forward and to kind of, oops, I just lost one of my earbuds, to speed up that process. And our first thoughts about these, and in our first paper, we focused on essentially trial designs, where there was some level of randomization happening somewhere, either at a patient level, more on the clinical effectiveness focus side, or more of a cluster provider level randomization if one's focus was more on comparing strategies or packages, or possibly this, dual randomized version. At that time, we went back and forth about, other possibilities, maybe having a 4th type, which, was observational study. We certainly, thought about, hey, people might want to do these kinds of things when all or some of this might not be randomized, but, we had already been spending a good deal of time on this paper. We wanted to get it out. So we focused on these trial designs, as kind of the ideal cases of this idea. And, that's really the origin story of it.
And I think one of the things that was so exciting for me at the time, watching this evolve and, communicating with you about it and using it in some early implementation studies, was the fact that these types of designs really put qualitative methods much more on the table, much more front and center in our implementation work, because, we can't do those evaluations of implementation processes, outcomes, and so forth without
and context, right,
without at least some qualitative work. And that's, you being a sociologist, me being an anthropologist, I mean, these were such great opportunities to look at much more of an integrated approach to evaluation that was,
yeah,
you can't do it without qualitative, which is of course very exciting.
Yes. I would also say too, that, all of us were in the VA working in then, sort of the first round of this query program, which, as a nationwide program, it was focused on trying to move the dial around uptake of certain guidelines and evidence-based practices, while also having research mechanisms to help us study how best to support these uptakes. at the same time. And so as the VA was and is, a very large healthcare system, and there are many times when they make decisions to support rollout of interventions that at times do not have super great clinical effectiveness data. So certainly the hybrid type 3 was fairly well suited for this commonality in the VA, where there were times when this was a system that was moving forward with trying to roll out something, but didn't really have a lot of great effectiveness data, randomized trial data. So using that variant, we were able to focus on testing how best to support uptake, but also providing clinical effectiveness outcomes if secondary. But we're still really needed by the system to have confidence that these interventions, which were being supported by a lot of money and operational effort, were actually working and were good for veterans and making care and outcomes better.
Yeah.
So there is a question coming through Q&A. So this is a anonymous attendee raising a question about the difference between a pragmatic trial and hybrid type 2. So you.
Yeah, that's a really good question. And another VA colleague of mine, John Fortney, and I are actually in the process of trying to write a paper where we draw very firm parallels between hybrid type 2s and a pragmatic trial. I mean, I think it's pretty similar, frankly. So that's a great question.
And then Cassidy, hi Cassidy, asked, would you consider a trial a true hybrid design if there is no clinical effectiveness component, but the effectiveness is focused on the implementation strategy or strategies? Or are we then just doing an implementation trial? I've heard various opinions about this and remain confused.
So my sort of initial gut reaction is, if you're not really looking at any outcome that has to do with how that clinical effectiveness intervention is performing on symptoms and functioning, and you're only really focused on things like how it's being adopted, its level of reach, fidelity, the quality of delivery, then it doesn't seem like it's a hybrid type 3 to me. I mean, it just makes me think about when we first started writing about this, and in our own minds, and this is 10 years ago now or even more, I think we thought mostly that these were going to be like special cases that you would have to argue why it's a good idea to do one of these. And one of the things that seems to be changing, certainly in our minds, as the team that, helped write them, and as we're now doing a large review of how they're being used to help describe that, those efforts, and also to help provide some new thinking, some new guidance, some new recommendations. I mean, it seems like, at least for hybrid type 1s and for hybrid type 3s, they might be becoming more of a default. And I'm hearing people talk more about, trying to argue, well, why wouldn't we do a hybrid type 1 if we're at a clinical effectiveness level And if we show it to be clinically effective, wouldn't the next step be trying to focus on uptake? So why not take this opportunity in this clinical effectiveness trial to study implementability issues of the intervention, but also factors in the context that might need, to be addressed by additional implementation strategies. And I was at a meeting many years ago at the D&I conference, and it was on hybrids, and I wasn't even part of the development of the panel. I just kind of showed up to watch, and somebody during the Q&A said, "Okay, well, for hybrid type 3s, I mean, when wouldn't we want to look at these clinical effectiveness outcomes?" And I hadn't really thought of it like that until that person said so. We've been doing a lot of thinking about that lately, and one of my current mindsets is trying to figure out, okay, well, what are the situations when you don't need to do this, or maybe you shouldn't, and as we do this current review and are working on this review paper and papers, that's one thing that's in the discussion section of our overview paper is, when might these not, be necessary or helpful. For example, the most recent D&I study that I, wrote was not a hybrid 3. We were focusing on comparing strategies to support delivery uptake of COVID-19 vaccinations. And we aren't going to test whether the vaccinations are, keeping people from getting sick or getting COVID. Like, that's beyond the scope and, doesn't seem necessary. So we're only focusing on outcomes like adoption and reach, and not really looking at effectiveness. But then there are other situations, say in mental health interventions, where there's some adaptation going on, and it really seems like it makes a lot of sense to look at effectiveness outcomes and how they might seem to be related to the level of fidelity achieved. A lot of people think, well, we need perfect fidelity like in the trials, or else it isn't gonna work. Well, for some interventions, that's probably not the case. And how are we gonna know unless we have data from both sides? So those are my current thoughts.
Yeah, that's really helpful. So in this big review that you're doing, which I'm imagining like thousands of papers, I don't know if it's quite at that scope, but
no, I mean, it's taking a long time, and I'm really sorry to the field for it taking this long. There's a lot of papers, there's a lot of people that we're trying to code. We have to add in one more year's worth, and I wouldn't be surprised if we get to about 200 studies to review, which takes a lot of time. So yeah, we are learning, a whole lot. The main thrust of this is to just document how people are trying to use these designs. As I said, that first paper, really had trial designs. We are seeing a lot of people use them without randomization, one-arm studies on both sides, rollout type designs where they're not comparing two strategies, but kind of iterating one. Folks are doing this with pilot studies, like pilot hybrid type 1s, efficacy studies that they're trying to make hybrid type 1. So I mean, it seems to be turning more into maybe it's less about design or randomization, but it's more about this notion of trying to study some intervention and how it needs to be or is being supported for adoption at the same time. So, trying to combine various questions from both sides. And so it seems to be, more of an approach. I mean, from the start, we were using a fairly liberal definition of design anyway, because people use these in cluster randomized trials, in step wedges, in smart designs, rollout designs. I mean, in some ways, it's not a separate design, but it's an approach that can be used with, with all of these. But our first attempt was focused on trial designs and some level of randomization. But lots of people aren't doing that, and it seems to be working, I think. Our reviews are showing that it's not always easy to decide, well, which hybrid should I do, or which hybrid design am I doing? We've had about 24 or 25 of these studies which we're reviewing, which said that they were doing a hybrid, but they didn't say which hybrid type it was.
Yeah.
I assume that was part of just how hard it might be under certain circumstances, depending upon the kind of intervention, for example, to really discern or know. And I've had lots of consultations with folks where it's not always easy to land on well, this is definitely a 1, this is definitely a 2. So there's some confusion and gray area still, especially around hybrid 1 and 2. In a recent paper headed up by Sarah Landis and with Sasha McBain, we tried to bring some new thinking recommendations on this sort of 1 versus 2 distinction. I think that we want to bring more to it after this review. So we are learning a lot about how people are trying to apply these concepts. Some of the struggles and the understandable struggles that folks are having. And, we hope to bring, more updates, recommendations, help with distinctions. We have a draft tool, now with a series of questions, which is not yet published, but will be with these upcoming review papers that should help people to kind of land on an appropriate hybrid based upon how much, that they know about the effectiveness of their intervention, how much they know about their context. If they or other people have already tried strategies and they didn't work so well, how much pilot data that you might have on strategies, to help people land on kind of a good starting point with a hybrid, if indeed that is indicated, but also to help folks to, be steered away from them if it's not really necessary.
I mean, I think one of the when I'm teaching about hybrid designs, one of the things that I have emphasized is, this distinction between a 1 and a 2 of whether your evaluation is going to affect what you're doing during the course of the trial, with the idea that in the type 1, you're still basically doing an effectiveness trial and studying some implementation kind of around it or on the side, versus
Yes.
in type 2, you're actually informing your next steps with implementation based on what you're learning in the evaluation, which has all kinds of implications for the speed of analysis and your mixed methods and all of that. And are you
Sure.
seeing, I guess what I'm wondering is that still accurate? And are you seeing in
Yeah.
your review that that's like a reasonable distinction to be making still, or is there kind of
Yeah.
a different way of thinking about that now?
Yeah, I would just add to it. So for me, some key distinctions between 1 and 2 are kind of thus. In a hybrid type 2, it's really crucial for people to have implementation strategies that they have developed that they think, at least in part, are feasible and are going to work in the real world. And they have flipped over to the point where at least some of their strategies that they want to use, even in a pilot strategy format where all the places are going to get the same strategy, for it to be a type 2, for me anyway, folks really have to think that most or all of those strategy components are thought to be feasible and effective in the real world. We are actually trying to test a strategy which could work in the real world. And that's a clear distinction from a more classic hybrid type 1, where, I mean, let's face it, in every clinical effectiveness trial, people are using implementation strategies to deliver the intervention.
Sure.
We normally just don't call them that.
Mhm.
And they are normally, heavy resourced, controlled by the study. We're paying clinics to take part. We're paying participants. We're paying interventionists. We're really making sure that they deliver with fidelity. But moving into hybrid type 2, you're getting away from some of that researcher control into more, let's test some of the strategies which might actually be viable in the real world. I think that's a really clear distinction.
Mhm.
The other is in a hybrid type 1, well, in a hybrid type 2, you are going to be measuring more summative implementation outcomes. You are going to measure reach. You're going to measure adoption. You're probably going to measure fidelity in such a way that you're trying to evaluate these strategies which you are proposing to be feasible and effective, in this more real world study. A lot of hybrid type 1s don't even measure those, or don't measure them as implementation outcomes. And it might be more about studying the context, barriers to future uptake, analysis of, well, what should the strategies be in a future study that is more real world focused, or more focused on testing strategies.
Mhm.
So these are some of the key differences which in our review paper we will be talking about more,
Mhm.
which
Mhm.
we hope will be helpful.
Yeah.
I have a question about, say, for example, when you're comparing two implementation strategies, then the unit of analysis is often setting a cluster, right? So how would you
Mhm.
justify the sample size? Because in order to achieve the power, you often need like a lot of clusters, which is sometimes
That
not feasible, right? Not affordable.
that is true. You know, and so, you know, for a hybrid type 3, where that's very common, you know, where, you know, there's strategies being compared in a cluster design, you know, that's something that, you know, one certainly needs to deal with. You know, there are some papers out there, not really maybe for just hybrids, but for cluster trials, you know, in this area to try to give people help with power and selecting the number of sites. I mean, it has to do with the effect size that you think that you're going to get, certainly. It also has something, you know, your design is also going to have something to do with what is the nature of your comparison. You know, are you comparing a strategy which you kind of want everybody to get and then add something else, or you want to start with one and then move to another, or you want to do a regular cluster randomized trial where these folks get A and these folks get B. So, you know, whether you're contemplating a cluster randomized trial, parallel cluster randomized trial, or a step wedge, you know, which is, you know, having people start with one and then switching to a new one or adding on something else, or maybe a smart design, you know, where what, you know, everybody might start with strategy A and then maybe only move to strategy B or some other combinations based upon performance, you know, on their response to the first strategy. So, you know, your design is being driven a lot by how you want to study these strategies, and are they add-ons? Are they completely separate? Can you start one first and not the other? And you know, these have a lot to do with power also, right? So it's often a combination of, well, what are the research questions and what might be the optimal designs for the questions? And then of course, in D&I research, we're working out there, you know, in real world clinics, and they have to agree to do what we propose. And there are times when, you know, folks only want to do a step wedge because they don't want to be randomized to the intervention that might not be best, which then has implications, you know, for power. You know, these are complicated questions, but lots of hybrid type 3s and the non-hybrid type implementation trials often have a lot of sites. For example, in the last two that we wrote, which were focused on community pharmacies, you know, we had 50 pharmacies, which, you know, we were randomizing in various ways. You know, I've seen hybrid type 3s done in the VA in a step wedge design with 8 sites, with 12 sites. So, I mean, it does kind of depend on your ability on the effect size, your ability to, match. I mean, it's a complicated thing for sure.
I think one of the most common questions, wait, I'm gonna look at this chat, which I want to make sure that I catch Elena's question here, which is, that's from your overview paper, that researchers from clinical and implementation backgrounds often don't share concepts, constructs, and vocabulary. Sometimes the vocabulary is the same, but the meanings are different. It makes it difficult for researchers from different traditions to communicate effectively and efficiently, which could be a barrier to collaboration and impede comprehension. So she's wondering if you could just say a little bit more about strategies that could potentially overcome these types of challenges.
I mean, I think that my first thought is that in 2021, I mean, I think more and more people have heard of our kind of science and of D&I science. And I think more of us have also been paying attention to clinical effectiveness work and designs. So this might not be as much of a problem as it has been before, perhaps. I mean, there's a lot of team science going on. I am a sociologist by training, so I have never done work like this without having clinician partners. And, maybe in the first study, with a new team, there's some of this stuff that has to be worked out, like, hey, let's keep the term strategy for the intervention that is dealing with uptake, and let's keep intervention for the clinical prevention side thing, even though they're both interventions. And let's try to use some of these terms to help us differentiate. I mean, it seems like, though, that it's not as much of a challenge as it might have been 10 years ago.
Yeah, I agree. It's not.
Yeah, I really like the teaching slide that you put that together, like referring evidence-based intervention as the thing. Right? How do we promote that thing? Yeah, that's very clear and intuitive for beginners.
Okay, good.
I was thinking we should include that in what we send out to folks after today's session as well.
And also, it also kind of helps for not beginners. I mean, half of that, or even more of that idea and language came from me doing, years of consultations with a wide variety of people, many clinicians or clinical trialists, and, them coming to me and saying, okay, I have this intervention and we've shown that it works, and I need help now to help people to do it. And then my first question started to be, okay, so tell me, all right, so what is the thing that you're trying to get folks to do or to not do if it's de-uptake? And the thing can be lots of different kinds of things. I mean, it could be a clinical intervention. It could be a health promotion intervention. It could be screening. It could be a guideline. It could be a services linkage intervention, which isn't necessarily a clinical intervention. So, first, okay, what is the thing? And, what do you know already about how easy or hard it is to do the thing? And then we'll go from there. And it does seem to help us to kind of get on the same page faster, which helps.
Yeah, I mean, sometimes in talking with with people who have a lot of experience, you realize we all have a different thought about what the thing is. You're like,
Yeah.
wait, we actually all need to come to agreement on that before we can move forward with the next
Well,
decisions that need to
right.
be made.
Well, right. And another recommendation, which, we will hit hard in these new papers, it is mentioned in the Landis paper from 2019, is just this, is that when people are trying to write these grants to just get funded, and certainly with your paper afterwards, it's really important to be really clear about what the components of the thing are, and then what the components of the strategies to help people to do the thing. And it's not always easy. For example, telemedicine, these sort of delivery type strategies or approaches, a virtual intervention, telehealth. I mean, is that more part of the thing, or are those implementation strategies? And not everybody agrees, and it can be really hard to lay out and be clear, okay, well, what's all the parts of the thing and what are the strategies to help them to do the thing?
Right.
It's not always easy.
So I think we have time for at least one more question. And then if there are other questions that come in, we'll do our best to get those answered in writing after the session. But there was a question about if you want to implement an intervention that is relatively benign as far as the intervention itself, but has demonstrated effectiveness as far as outcomes, however, is not used due to primarily provider bias. Do you have to randomize sites? Could you introduce the intervention and study how implementation occurs? Does that cross into dissemination?
Interesting question. I would say that, I think it just kind of depends on the goals of what you're trying to do and what you're trying to study and what the healthcare system that you might be working with wants. It could very well be that the healthcare system has no appetite to do some trial of competing strategies. And people might just want to try to, hey, let's try to figure out a strategy that we think might work, and let's try to use it in a bunch of places as like an eval of a program, and then we can mess with it over time, basically just trying to maximize the one strategy that we think is going to work, because they want to go as fast as possible to meet adoption benchmarks. And I think that that's perfectly valid. Not everybody wants to write a study where they're comparing strategies in some controlled way, or even after they've adapted some intervention, do a new clinical trial of it. They just kind of want to start to use it and look at outcomes. And in the kinds of highly partnered work that Allison does in the VA and other places, that's relatively common, right,
Yeah.
Allison?
Oh, definitely. Yeah, it's probably the norm. It's so common that that's pretty much always the case. Yeah,
right,
definitely.
right.
Okay,
have
I know
time for another one.
Well, I'm torn because I think we probably have two more questions, but I also wanted to just show folks what was in those remaining slides to let them know that you provided those guiding questions, the kind of revised guiding questions. So
yeah,
is the one that you have, Chen Ching, is it a quick one?
Yes. So these are the suggested reference we're gonna share after this chat. And
And then Geoff, you want to just walk us through this real quick, just so they kind of know, folks know what they've got here?
Yeah, super fast. So when about 2 years ago, we started to use this document here to help people who came to a workshop with a project that they had in mind, and they weren't exactly sure if they needed a hybrid or wanted one, or which one might sort of be the best landing spot. So we came up with these questions to try to help people land on a hybrid type that makes the most sense. And it starts with this question of the nature of the effectiveness of your intervention or of the thing. And so if it's, very to pretty darn strong already, and it doesn't seem like a lot of adaptation needs to take place for a new context or population. I mean, it seems like you're probably ready to think about a hybrid type 3 or possibly a type 2, depending upon how much you already know about implementation needs and factors. If your intervention has more mixed results, or doesn't really have very strong effectiveness results, you are likely more in a hybrid type 1 or kind of early type 2 category. Next, how much do you expect that the intervention will need to be adapted for where you want to use it in a new context, a new population provided by a different provider? If you think that you need to do, a lot of adaptation, you might be in more of a hybrid type 1 scenario, or possibly a type 2, which is still intervention focused, but moving towards a, pilot implementation strategy version. The next question, have you or somebody else already tried an implementation strategy or package of them, which hasn't really worked well? This is actually a common starting point for lots of our work is, some dissemination of a guideline or practice has already happened. Some implementation as usual strategy package has been tried. It didn't really work well. And if that is where you're starting and your intervention already has strong effectiveness data, you're already kind of starting either in a type 2 or a type 3 situation. Do you already have pilot data on a strategy or package that you want to test in a comparative study? And if that's yes, and it's, and you have strong intervention effectiveness data, you are clearly in a type 3 scenario. And then our last question is just kind of a joke. So if answering all of these questions, you are being scared off of hybrid designs, that's certainly fine, and feel free to run screaming from the room or from our beach here. If you still want to move forward, there's resources available. The Landis paper from 2020 has some, nice new new recommendations. There's, 180 protocol papers out there, which you can look at and to try to find a model or models of what you want to try to do. There are folks like me and Sarah and others in my group who do a lot of consultations with people to help them figure this out. So that's available too.
Thank you so much, Geoff. Running from the beach. So that was wonderful. I could keep you here for the rest of the day, but we will wrap up. Feel free that our hub email will be on the next slide, but feel free to reach out to us. As I mentioned, Geoff is one of our illustrious consultants, and our hub has a wonderful group of folks who are all willing to help. We're really excited that next month's Beachside Chat is with Matt Chinman, who is, another one of our consultants and another implementation scientist extraordinaire. And then we'll have Russ Glasgow with us in May. So we hope you tune in to the upcoming Beachside Chats. And if you just want to go to the next slide, Jen Ching, we thank you so much for being here, especially Geoff. Thank you to you for taking this time. I think you're actually technically on vacation today, so extra thank you for taking an hour with us.
Sure.
I always appreciate your expertise and wisdom. For everyone in the audience, we really would appreciate you completing our super brief evaluation afterwards. And if you have any questions, feel free to reach out to us. We'd love to hear from you. So thanks everyone, and have a great rest of your week. Thank you so much. Take care, everyone. Bye.
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 Thank you, Chen Ching. Thanks, Elena.
Thank you. Bye.